Hey guys, welcome back to our channel. Today we are going to discuss about the case history in periodontology, that is part 2. In the first part we have seen the external structures and external features of gingiva. Today we will see the examination of the periodontium and the remaining part to be seen in case history. So first of all, examination of periodontium done in a systemic way, examining all the surfaces of every tooth and record the findings in the periodontal chart, pocket depth and clinical attachment level. Note that normally the gingiva is 1 to 2 mm above the CJ, 1 to 2 mm above the CJ. If it is below the CAJ, it is known as gingival recession. If it is above the CAJ, it is known as gingival enlargement, which can be caused by the drugs like phenytoin. And gingival recession may have many reasons. So this is known as, if the gingival recession is present, we say that clinical attachment loss has happened. Okay. So first of all, what is pocket depth? The distance between the gingival margin and the base of the pocket. Normally the gingival sulcus depth is 2 to 3 mm. If it is more than 2 to 3 mm, it is known as pocket. So the pocket depth is the distance between the gingival margin and the base of the pocket. Second is the clinical attachment level, the distance between the CJ and the base of the pocket. Imagine this is the pocket and this is the CJ. So this is the clinical attachment level and this is the pocket depth. So clinical attachment level, this is the clinical attachment level, this is the gingival margin and this is the pocket depth, this is the CJ. So how to calculate clinical attachment level or clinical attachment loss? So first of all, if there is calculating cal in the presence of recession of gingival margin, or if there is gingival recession. When recession of the gingival margin is present, the cal is calculated by adding the probing depth to the gingival margin level. So how to calculate cal? Cal is equals to probing depth plus gingival recession. It is very important. Okay. So imagine if the probing depth is 4 mm and gingival margin level is 2 mm, the clinical attachment loss will be 6 mm. This whole will be, this is the gingival recession, this is the gingival recession, this is the probing depth, this is the gingival recession. Cal will be both of this, so it will be probing depth plus gingival recession. Next is the calculating cal when the gingival margin covers the CJ. If the gingival margin is covering the CJ, like in the case of gingival enlargement. So what we have to do, we have to minus the gingival enlargement minus the probing depth. So probing depth minus gingival enlargement gives us cal. What it gives? It gives us cal. When the gingival margin is coronal to the CJ, the cal is calculated by subtracting the gingival margin level from the probing depth. Probing depth minus gingival margin level. Okay, if it is 9 mm minus 3 mm, the clinical attachment loss will be 6 mm. Now, calculating cal when the gingival margin is the normal level, that is at the CJ. When the gingival margin is slightly coronal to CJ, that is 1 to 2 mm coronal to CJ, no calculation are needed since the probing depth and a clinical attachment level are equal. Probing depth measurement approximately 6 mm, that is it is 2 to 3 mm in normal individual. So clinical attachment level or loss will be 0. Just cut this. Clinical attachment loss will be 0. Gingival recession will be 0. Probing depth will be 2 mm. So we will write like this: 2, 0, 0. If there is presence of gingival recession and pocket, so we will write 3, 1, and so adding this 2 will become 4. So this is my probing depth, this is my gingival recession, and this is my cal. Next, the next feature we have to see is tooth mobility. Tooth mobility, the movement of tooth in the socket resulting from an applied force. Physiologic tooth mobility present normally. There is some amount of mobility present physiologically. Apply firm pressure with either one metal instrument and a gloved finger or two metal instrument. How to check the mobility? Use two instruments or one instrument and one finger, gloved finger, to check the mobility. There are two famous classification for checking tooth mobility. First is the Miller's classification given in 1985. Normal, physiologic tooth mobility, class 1 mobility, mobility less than 1 mm in horizontal direction, mobility less than 1 mm in horizontal direction. Class 2 mobility more than 1 mm in horizontal direction. More than 1 mm, this is class 1, this is class 2. Class 3 mobility more than 1 mm in horizontal and vertical direction. Horizontal as well as vertical direction is known as class 3 mobility. The next classification we have is Glickman's classification 1972. Grade 1, grade 2, grade 3. Grade 1 is slightly more than normal, that is physiologic mobility, moderately more than normal, and severe tooth mobility, faciolingually or mesiodistally with vertical displacement. Faciolingually mobility will be there, or mesiodistally mobility will be there, as well as there will be vertical displacement. Okay. Slight, moderate, severe. Severe may be faciolingual or mesiodistal plus vertical. This is the classification given by Glickman in 1972. The next thing we have is furcation involvement. The extension of inflammatory periodontal disease into the interradicular area of the multi-rooted teeth is known as furcation involvement. So, the extension of inflammation of periodontal disease into the interradicular area. As we know the parts of tooth, imagine this is a tooth. Okay, imagine this is a tooth and this is the crown portion. This is known as root trunk. These are my two bifurcated roots. This is my crown. So this is known as furcation area. This hole is known as furcation area. So if the inflammatory disease is into the interradicular area of the multi-rooted teeth is known as furcation involvement. Diagnosis is based on clinical and radiographic findings. Clinical detection, we have to use neighbor's probe. In the case of mandibular molar furcation, easy to detect since there are only two roots. As we know, in the mandibular molar, there are only two roots which are distally tilted. In the maxillary molar furcation, mesial furcation, go for palatal direction. Mesial furcation is located parallel. So one thing we have to note in maxillary, when we have to check mesial furcation, it is palatal to the midline. If this is the midline, it is palatal, that is, it is lingually to the midline, and in the case of distal furcation, it is at the midline. So remember always, mesial furcation is palatal to midline and distal furcation is at the midline. So the mesial furcation go for palatal direction. Mesial furcation is located parallel to the midpoint on mesial surface. Distal furcation located more towards the midline, detect by either buccal or palatal approach. How to check distal furcation? By buccal or palatal approach. So the Glickman's classification for furcation horizontal component, that is according to Glickman in 1953, there are four classification: grade 1, grade 2, grade 3, grade 4. Grade 1 is the incipient or early stage of furcation involvement, supra bony pocket, and primarily affects soft tissue, no radiographic changes. As you can see, this is the grade 1 furcation, this is the grade 2, this is grade 3, and this is grade 4. As you can see, only depression is seen. So you have to keep the neighbor's probe here. You can see a depressed area. So this is grade 1, that is incipient or early stage of furcation involvement, supra bony pocket, and primarily affects soft tissues. It has only affected the soft tissues and there are no radiographic changes. In the case of grade 2, there is skull-D sac, that is dead end with a definite horizontal. It's like you have to if this is your tooth and this is the furcation, you have to insert neighbor's probe, and at one point the neighbor's probe will be stopped, so it will get a dead end. So it is known as skull-D sac effect with a definite horizontal component, so we have to insert the neighbor's probe. So we got the horizontal, this is the horizontal component. Radiographs may or may not be depict furcation involvement. As you can see, you can insert the neighbor's probe inside this. You can't insert in this, but you can insert in this. So this is grade 2. Furcation. In the grade 3, bone is not attached to the dome of the furcation. Difficulty in passing the probe through the furcation because of the interference with the bifocal ridges or facial or lingual bony margins. Radiographically, radiolucent area in the crotch of the tooth. So one thing you have to remember for grade 3, that bone is not attached to the dome of the furcation. There is no attachment of bone at the dome of furcation. Difficulty in passing the probe through the furcation because of the interference with the bifocal ridges or bony margin. When I am inserting, so we can see grade 3 furcation on maxillary molars. Probing confirms that the buccal furcation connects with the distal furcation of both these molars. The buccal furcation connects with the distal furcation. There is any presence of bony margins. Radiolucent area can be seen in the crotch of the tooth. So this is the crotch of the tooth. Radiolucent area, that is black, will appear in radiograph. The grade 4 furcation involvement is the interdental bone is destroyed and the soft tissues have receded apically so that the furcation opening is clinically visible. If it is clinically visible, as you can see, the furcation is very clearly clinically visible, so it is known as grade 4, where interdental bone is destroyed and soft tissues have receded. Periodontal probe can pass easily from aspect of the tooth to other. So you can use a periodontal probe. Here we have to use neighbor's probe. Here also we have to use neighbor's probe. Here neighbor's probe. We have to use neighbor's probe here also, but you can use periodontal probe also. So this was all about the furcation involvement. So the next classification we have is Tarnow and Fletcher's classification given in 1984 for vertical component, that is depending on the distance from the base of the defect to the roof of the furcation. As we know, this is the furcation. If only 1 to 3 mm is involved, so it is subgroup A. If it is 4 to 6 mm involved, it is subgroup B, and if more than 7 mm is involved, it is subgroup C. For subgroup A, vertical destruction of bone up to 1/3 of the interradicular height, that is 1 to 3 mm. Subgroup B, vertical destruction of bone up to 2/3 of the interradicular height, that is 4 to 6 mm. Subgroup C, vertical destruction beyond the apical third, that is 7 mm or more, is the subgroup C. The next we have is gingival recession. What is the meaning of gingival recession? The apical migration of the gingival margin from the normal position at the CEJ is known as gingival recession. As you can see, this is the normal position of gingiva. It has apically or migrated towards the apex. Therefore, it is known as gingival recession. The Cleven and Atkins classification of gingival recession according to 1968 is shallow, narrow, shallow, wide, deep, narrow, and deep, wide. It is very easy. Shallow, narrow, shallow, wide, deep, narrow, and deep, wide. So this is shallow, narrow, shallow, wide, deep, narrow, deep, wide. The next classification we have is Miller's classification of gingival recession given in 1985, which is of utmost importance. The class 1 according to Miller's classification of gingival recession is marginal tissue recession not extending to the mucogingival junction. No loss of interdental bone or soft tissue. So it is not extending to the mucogingival junction. In class 2, marginal tissue recession extends to the to or beyond the mucogingival junction. It is extending to the mucogingival junction, but there is no bone or soft tissue injury. In the third case, marginal tissue recession extends to or beyond the mucogingival junction. Mucogingival junction, it is crossing. Loss of interdental bone or soft tissue loss is seen, or teeth malpositioning. There is malpositioning of the teeth. In class 4, marginal tissue recession extends beyond the mucogingival junction. Mucogingival junction extend करता है. Loss of interdental bone and soft tissue. Interdental bone and soft tissue is also lost interdentally, or severe tooth malpositioning. There is severe loss of interdental bone and soft tissue, and there is severe tooth malpositioning. This is the Miller's classification. As you can see, it is not extending the mucogingival junction. It is extending the mucogingival junction. Mucogingival junction tak hai. Here also mucogingival junction, it is extending. But in this case, there is no soft tissue harm. In this case also, there is no soft tissue harm. In this case, soft tissue or bone harm is there. And in this case, there is severe bone or soft tissue loss. So this is the grade 4 or class 4. This was class 1, class 2, class 3, class 4. You can see here no mucogingival junction, up to mucogingival junction, up to mucogingival junction, up to mucogingival junction. No bone or soft tissue loss, bone or soft tissue loss, and severe bone or soft tissue loss. The next part is the width of attached gingiva. How to check the attached gingiva? First, you have to identify two landmarks, that is sulcus or pocket depth and mucogingival junction. So, if this is the sulcus or pocket depth and the mucogingival junction, how to check? This is the, imagine this is the attached gingiva and this is the normal gingiva. That is this is our mucogingival junction till sulcus depth. This is known as attached gingiva, width of attached gingiva. Okay, so this is the, as you can see, this is the sulcus depth and this is the mucogingival junction. This is the width of attached gingiva. Identify two landmarks, sulcus or pocket depth and mucogingival junction. For mucogingival junction, how to identify this mucogingival junction? We can do tension test and roll test. Tension test is important in the case of in the point of view case history. Stretch the lip or cheek outwards. Identify the junction of immovable attached gingiva and movable alveolar mucosa. If we have to stretch the lip, so the part which moves is the alveolar mucosa and the part which doesn't move is the attached gingiva. Next test, we can do the roll test. Roll the alveolar mucosa over the attached gingiva with a blunt instrument. As you can see here, we have to use the attached blunt instrument and roll the attached gingiva with a blunt instrument. Here the movable alveolar mucosa accumulates ahead of the instrument till the mucogingival junction when pushed coronally. So you have to roll over the alveolar mucosa over the attached gingiva. Roll the alveolar mucosa over the attached gingiva. It will accumulate till the mucogingival junction. When pushed coronally, we have to come towards coronal direction. Tension test is more important than roll test. Now, measurement approach. How to measure it? Measure the sulcus or pocket depth. Measure the distance from the gingival margin to the mucogingival junction. Subtract the two measures is the width of gingiva. Very simple. This is the gingival margin to the mucogingival junction, and this is the sulcus depth. So whole minus sulcus depth, we got the width of attached gingiva. So we get the width of attached gingiva. Simple. Next we can do the histochemical method for attached gingiva's width. For alveolar mucosa, remember the alveolar mucosa appears brown and the attached gingiva remains unstained. As alveolar mucosa has glycogen, so it appears brown, and attached gingiva is glycogen free, so it is unstained. Histochemical method used is Schiller's potassium or Lugal's iodine is painted on the gingiva and oral mucosa. Due to the glycogen content of alveolar mucosa, it appears brown, while the attached gingiva is glycogen free, so it appears unstained. Now measure the total width of unstained gingiva and subtract the, so you have to measure this attached gingiva minus the sulcus depth to get the width of the attached gingiva. Grade test in this data is very important as per the Carranza. So you have to remember in the incisor region, maxilla and mandible. In the case of incisor region, maxilla and mandible. In the case of incisor region, in the case of premolar, in the incisor region it is 1.9 mm, and in the incisor region, maxilla, mandible, incisor region, premolar region, 1.9 mm, 1.8 mm. Here in the incisor region, 3.4 to 4.5 mm, and in the mandible 3.3 to 3.9 mm. So the maximum can be seen. So the maximum can be seen in incisor region of maxilla, and minimum can be seen in the premolar region of mandible. So it is a MCQ question. The greatest in the incisor region, that is 3.5 to 4.5. Here it is 5. 3.5 to 4.5 millimeter in maxilla and 3.3 to 3.9 mm in mandible, and less in the first premolar region, that is 1.9 mm in maxilla and 1.8 mm in mandible. Next we have is the depth of vestibule related to the width of attached gingiva. If the width is normal, the vestibular depth is adequate. If the width of attached gingiva is minimal, that is shallow vestibule, vestibular depth is inadequate. If the width of attached gingiva is less, so we can say it is a shallow vestibule. What we can say? It is a shallow vestibule if the width of the attached gingiva is less. Next we have the frenum attachment. For frenum attachment we have to do the tension test. In the tension test, lip is moved outwards, upwards or downward, and in sidewards. Marginal or interdental papilla moves away from the tooth surface. Positive tension test. Normally the marginal gingiva or interdental papilla doesn't move away from the tooth surface. If it is positive, so we can do the plaque classification according to 1974. Marginal gingival junction, mucosal, attached gingiva, gingival, and IDP is papillary. So the plaque classification is mucosal, tension test is mucosal, gingival, papillary and papilla penetrating. For mucosal, frenal fibers are attached up to the mucogingival junction, that is mucosal. In the case of gingival, frenal fibers are attached within the attached gingiva. In the case of gingival, the frenal fibers are attached within the gingiva. In the case of papillary, fibers extend into the interdental papilla, and in the papilla penetrating, the frenal fibers cross the alveolar process and extend up to the palatine papilla. Imagine this is the labial direction of papilla and this is the lingual direction of papilla. So it extends to the labial to the lingual direction. So mucosal frenal fibers attached to the mucogingival junction, then to the attached gingiva, then to the interdental papilla. You just have to remember this: mucogingival junction, attached gingiva and interdental papilla. The name is accordingly mucosal, gingival and papillary. And papilla penetrating is alveolar, it crosses the alveolar process and extends up to the palatine papilla. As you can see here, this is the tension test for the frenum attachment. Tension test for frenum attachment. The next we have is the abscess. There are 4 kinds of abscess we must know. First is the gingival abscess, second is the periodontal, third is pericoronal and fourth is periapical. So this is the abscess. As you can see here, while probing, the pus is coming out. Purulent discharge. The gingival abscess is the characteristic of gingival abscess is it is localized painful swelling affecting marginal and interdental gingiva. It is caused due to impaction of foreign objects like fish bone or popcorn kernel. Next we have periodontal abscess. It is also localized purulent inflammation of periodontal tissue including deep pockets, furcation, vertical osseous defects, lateral or parietal abscess. Next we have is pericoronal abscess. It is also localized purulent inflammation surrounding, purulent is nothing but pus forming, surrounding crown of partially or fully erupted teeth. It is very important. Pericoronitis is seen in the case of partially erupted teeth or in the case of third molar. Next we have is periapical abscess, localized purulent inflammation surrounding apex of the tooth. It is more commonly seen in endo. Periapical abscess. So gingival, periodontal, pericoronal and periapical. As you can see, this is the periodontal abscess. The next is we have used periodontal probe. Gently digital pressure may be sufficient to express the purulent discharge. You have to use the digital pressure. Radiographic findings used to know the extent of periodontal destruction in the form of bone loss. Periapical radiographs or orthopantogram. We can use IOPA or OPG. Record the amount of bone remaining, bone density, continuity of lamina dura, radiolucent areas and pattern of bone loss. What we have to notice: the bone remodeling, what is the density of the bone, is the continuity of lamina dura intact, and where we can see the radiolucent areas, and what is the pattern of bone loss. As you can see here, severe bone loss can be seen. The next and foremost important thing is the provisional diagnosis, initially determined to be the diagnosis followed by investigation which help in making the final diagnosis. So the four characteristics, or I would say the five characteristics which are very important while writing diagnosis is it generalized or localized? It is mild, moderate, or severe? Is it marginal, marginal and papillary or diffuse? Is it chronic or acute? Is it gingivitis or periodontitis? So these are the five characteristics for provisional diagnosis. So how to write the diagnosis? Is it generalized or localized? We see 28 sites. We see 28 sites in the periodontal charting. So what is the 30% of 128 sites? Approximately 38 sites. If more than 38 sites are involved, it is generalized. If it is less than 38 sites, it is localized. Simple. How to write generalized and localized? If more than 30% of sites involved, and if it less than 30% sites involved. Next we have is mild, moderate, severe after recording the mean cal. So if we got the mean clinical attachment loss, if it is 1 to 2 mm, it is mild, 3 to 4 mm moderate, if it is severe, more than 5 mm. So this is the second diagnosis. The third diagnosis is marginal and papillary and diffuse. So first of all, marginal is nothing but this marginal. If only this is inflamed, so it will be marginal. If along with the marginal, the papilla, the interdental papilla, marginal plus interdental papilla is also inflamed, so it is marginal and papillary. We will tell it as marginal and papillary. And if along with this marginal plus interdental papilla plus there is loss of stippling is absent, so we will say it is a diffuse. Why? Because stippling is only seen in the case of attached gingiva. It is only seen in the case of attached gingiva. So it's very simple. If stippling is present, it is not a diffused, and if stippling is absent, it is a diffused gingivitis. Simple. So you can write the third characteristics. Is it marginal or papillary, and diffuse? Marginal, papillary and attached gingiva normal. Okay. Next we have is the chronic or acute. Next we have chronic or acute. Okay. So in the case of chronic or acute, so it's very simple. Acute for a very short duration and chronic it is from long duration. The last but not the least is the gingivitis and periodontitis. The last but not the least is the gingivitis and periodontitis. Remember, the patient can be having only gingivitis, only periodontitis, as well as the patient can be having periodontitis as well as gingivitis. So in the case of gingivitis and in the case of periodontitis, gingivitis can be localized, generalized, mild, moderate, severe, marginal, papillary, diffuse, acute and chronic. For the periodontitis, there are some points you have to always remember. If in the case of gingival recession, in the case of periodontal pocket or cal, that is clinical attachment loss, it is a short case of periodontitis. So in any case, if you see gingival recession, periodontal pocket or clinical attachment loss, you have to write the diagnosis as periodontitis. Simple. So for example, I will give you a diagnosis. So imagine a patient is having, so the first, second, third, fourth, fifth. So imagine a case in which the person is having gingival recession with respect to 3-1 and 4-1, and he is also having gingivitis in the case of anterior tooth. So I will write first thing localized or generalized. So less than 38 sites, so localized. Less than 38 sites. Mild, moderate or severe, imagine it is a mild because it is 1 to 2 mm. Next we have to write is the marginal papillary or diffuse. Imagine it is a diffuse. Why? Because stippling is absent. And local, chronic or acute? Chronic. Gingivitis. And so the gingival recession is also there. So localized periodontitis with respect to 3-1 and 4-1. Simple. So this is one example of diagnosis, how to write it. Localized mild diffuse chronic gingivitis and localized periodontitis with respect to 3-1 and 4-1. If it is localized, you can also mention the gingivitis with respect to, imagine it has only in the upper anterior 1-2 and 1-2. Very simple. ठीक है. So this was all about the diagnosis. The next is how to record cal. In this, how to write it, it's very simple. The first thing is the probing depth, second is the gingival recession, and third in the case of cal. So I will give you two scenarios, if it is a diseased person and if it is a happy person, like non-diseased person. In the case of diseased person, the periodontal depth approximately is 4 mm, gingival recession is 2 mm, so the clinical attachment loss will be 6 mm. In the case of happy person, there will be 2 mm, the gingival recession is 0 and clinical attachment loss is 0. So you have to write like this: 2 0 0 4 2 6. And this is not occlusal, this is lingual. This is not occlusal, lingual. Mesial, distal, facial and lingual. So this was all about the how to record cal. Simple. As you can see here, gingival margin, base of pocket, gingival margin. So this is the clinical attachment loss. You have to note the gingival recession plus the probing depth. So you will get the cal, that is clinical attachment level. Next, you always have to remember that the normal sulcus depth is 2 to 3 mm. Very important. Now how to calculate mean cal? Mean cal is equals to 6 plus 5 2, that is severe. Mean cal is nothing but the average of the cal. Now next we have is the classification of periodontal disease, which is very important. It is according to 1999 WHO classification. Check it once. So the first is the gingival disease. Plaque induced gingival disease. Gingival disease modified by systemic factors like diabetes mellitus, puberty, pregnancy associated. Gingival disease modified by medications. Gingival disease modified by medications. Drug induced gingival diseases. Next we have non plaque induced gingival diseases like bacterial, viral, fungal, genetic origin. Gingival manifestations of systemic condition, allergic reaction, traumatic lesions, foreign body reactions. Next we have chronic periodontitis, aggressive periodontitis, periodontitis as a manifestation of systemic disease, necrotizing periodontal disease, abscess of periodontium, periodontitis associated with endocrine lesions, development and acquired deformities and condition, mucogingival deformities and condition, and occlusal trauma. There are two classification according to 1992 and 2012 or 17. Just check it once, which is the following classification. The next we have is the special investigation. We can do the routine blood examination like CBC, bleeding count, that is BT-CT, clotting time, hemoglobin levels, study cast, biopsy in the case of gingival overgrowth like gingival enlargement, microbiological analysis for culture for isolation, and identification of bacteria in the case of infections. The next is the final diagnosis. Complete and accurate diagnosis is important for an appropriate treatment plan. Treatment plan is of utmost importance in the case of case history. Final diagnosis should involve all the periodontal condition for which the patient requires treatment. It means if the patient is come in the perio department, it's not like that in the treatment plan I will only include the perio. If he is having any OS problem, I will include that too. Prostho problem like the FPD and everything, endo problem like RCT or restoration, I will involve or consider that too in my treatment plan, which is very important. Example, generalized marginal chronic gingivitis with localized severe chronic periodontitis with periodontal abscess or pericoronitis. Pericoronitis is seen in partially erupted tooth or third molar. Trauma from occlusion with respect to like any teeth. The next is the prognosis. Prognosis is very important. It is classified into 5 parts according to McGuire and Nunn. So this is the classification. This is the classification for prognosis, very important, given by Maguire and Nunn classification. So how you have to write? You have to write prognosis as per Maguire and Nunn. So there are two types of prognosis, overall and individual. So overall is the overall condition of systemic, including the systemic condition. Individual is with respect to any teeth, like 3-1 and 4-1. So you have to write individual is fair, good, fair, poor, questionable or hopeless. The same thing you have to write, good, fair, poor, questionable or hopeless, for overall also and for individual also. So how to write the prognosis according to Maguire and Nunn classification system. For good prognosis, there is this is the category you have to consider: control of etiological factors and enough clinical radiographical periodontal support to enable the tooth to be maintained by the patient and clinician with proper maintenance. So the prognosis will be considered as good. In the case of fair prognosis, approximately 25% attachment loss, that is CAL as measured clinically and radiographically, if there is class 1 furcation involvement. Very important, class 1 furcation comes in fair prognosis. The severity of furcation involvement would allow adequate maintenance. Next is the poor. If 50% CAL is seen and class 2 furcation, the location and degree of furcation would accommodate proper maintenance, although with difficulty. Questionable prognosis is more than 50% CAL, poor crown by root ratio, class 2 not easily assessed, or class 3 furcation involvement. Class 2 or class 3, class 2 mobility or more, and significant root proximity. And hopeless prognosis in the case of severe attachment loss, extraction performed or suggested. So this was all about the prognosis: good, fair, poor, questionable and hopeless. So prediction of the probable course, duration and outcome of the disease, where this is very important. Prognosis is the outcome of the disease based on the general knowledge of pathogenesis of the disease and the presence of risk factors for the disease. There is two kind of prognosis, overall and individual. Overall is considered, the factors to be considered is the patient's age, systemic factors, severity of disease, smoking, presence of plaque calculus, patient compliance, prosthetic possibilities. For individual, prognosis determined after overall prognosis and affected by it. The next is the treatment plan, which is very important. An accurate and complete diagnosis helps to formulate an appropriate treatment plan. It is divided into 4 phases. 4 is the maintenance phase. You have to remember this very clearly. Next we have is emergency phase, if the person is requiring emergency phase. Next we have is phase 1, also known as non-surgical or etiotrophic phase. Etiotrophic phase. Emergency phase is also known as preliminary phase. Now from phase 1, the patient can go into 2 directions. If he is requiring restoration or he is requiring any kind of surgical procedure. Okay. So in the case of restoration, it will be phase 3 and surgery is the phase 2. And after that again he will come to the maintenance phase, that is phase 4. So what is the order? The order we follow while writing the case history is very important. Imagine this is a treatment plan and the person is having occlusal caries. Occlusal caries comes in restorative phase. RCT comes in surgical phase. Extraction comes in surgical phase. Root scaling and root planing. Scaling and polishing is known as scaling and polishing. It is known as scaling, and root planing, it comes in phase 1. Restorative as phase 3. Surgical phase 2. Surgical phase 2. Restorative phase 3. Scaling root 1. Oral hygiene instruction phase 1. Maintenance phase 4. So if XYZ person is having occlusal caries with respect to 6 and 7, 3, 6 and 3, 7, as well as he is having root piece with respect to root piece. Asymptomatic root piece is there. If it's symptomatic, it will come in emergency phase. Asymptomatic root piece with respect to 8. Okay. So what is the treatment plan for the following patient? So treatment plan will be phase, there will be no emergency phase. Emergency phase, in the case of emergency phase, we will write not required. And next you will write phase 1 etiotrophic phase or non-surgical phase. Here you will write first scaling and root planing. Next you will write oral hygiene instruction very clearly that the XYZ person should be have to use medium toothbrush with fluoridated toothpaste using modified Stillman or Bass technique for twice daily, and also interdental aids are suggested for the patient. So you have to give the oral hygiene instructions very clearly. Then the patient is recalled or reviewed after 4 weeks. Then you have to write phase 4, that is maintenance phase. Review the patient. Next, for the occlusal caries, after phase 4 we have to come to the phase 4. Occlusal caries comes in the restoration part, so it will come in phase 3. So first do the phase 2 because he is also having the root piece. So root piece extraction with respect to 8 advised. Next we have phase 3, that is occlusal caries or restorative phase. Write the name of the phase. What is the name of the phase? Maintenance phase, restorative, surgical phase, restorative phase. So occlusal caries restoration with GIC or composite with respect to the tooth which was involved, that is 6, 7. So do this, and after this the patient once again will come to the phase 4, that is the maintenance phase. Review the patient. Okay. The most important, the last part of this is the remark. Remark is nothing but recall. Normally in the case of gingivitis we have to recall after 6 months, and for periodontitis in 2 to 3 months. In the case of periodontitis you have to write recall according to the Marin's classification. Recall according to the Marin's classification. This is very important. Recall according to the Marin's classification in the case of gingivitis and in the case of periodontitis. So this is how you are supposed to write the treatment plan. Emergency phase not required, phase 1 etiotrophic phase, non-surgical phase, scaling and root planing, oral hygiene instruction, recall or review after 4 weeks, phase 4 maintenance phase. Remember, the patient has to go in the maintenance phase irrespective of which phase he is going, phase 1, phase 2, phase 3, he has to come to the maintenance phase. Review the patient in the case of phase 2, that is surgical phase, root piece extraction with respect to 3-8 and 4-8 advised. Phase 3 restorative phase, occlusal caries restoration with GIC or composite with respect to 3-6 and 3-7. Phase 4 or maintenance phase, review the patient. Remark is the recall the patient in the case of gingivitis after 6 months and in the case of periodontitis in 2 to 3 months according to the Marin's classification. So there are 4 phases. If the patient is in pain, elimination of pain, other emergency treatment. That is the preliminary phase. After completion of phase 1 therapy, patient is placed on maintenance phase to preserve the results obtained and prevent any further deterioration and disease recurrence. Emergency phase, non-surgical phase, maintenance phase, that is phase 4. Surgical phase, phase 2. Restorative phase, phase 3. So one thing is that if the patient doesn't require a phase 2 and phase 3. So you will write phase 2 not required, phase 3 not required, and you will directly jump to the phase 4 or maintenance phase. Always you have to include the maintenance phase. So this was about the phases. You can see in detail when to what to do in different phases, like phases of periodontal therapy in the preliminary phase or emergency phase, treatment of emergency dental or periapical, periodontal, other, extraction of hopeless teeth. We have studied the prognosis and we know what is hopeless teeth, and provisional replacement if needed may be postponed to a more convenient time. Next is the non-surgical phase or phase 1 therapy, plaque control and patient education, diet control, removal of calculus and root planing, correction of restorative prosthetic irritational factor, excavation of caries and restoration, antimicrobial therapy, occlusal therapy, minor orthodontic treatment, provisional splinting and prosthesis, evaluation of response to non-surgical phase, rechecking pocket depth and gingival inflammation, plaque, calculus and caries. Surgical phase, phase 2 therapy, periodontal therapy, placement of implants and endodontic therapy comes in the surgery. Restorative phase, final restoration, FPD, RPD, evaluation of response to restorative procedure, periodontal examination. Maintenance phase, that is phase 4 therapy, periodic rechecking of the calculus, plaque, gingival condition, pocket inflammation, occlusion, tooth mobility and other pathological changes. So this is the recall interval for various classes of recall patient. The Marian classification, first year, class A, class B and class C. Just read all this recall intervals for 3 months, 1 to 2 months. Just read this, go through this. To summarize, that is in the first year 3 months if the first year patient routine therapy and uneventful healing, first year patient difficult case with complicated prosthesis, furcation involvement, poor crown to root ratio or questionable patient cooperation, 1 to 2 month recall. Class A 6 months to 1 year recall, class B 3 to 4 months, decide on recall interval based on number and severity of negative factor. Class C 1 to 3 months, decide on recall interval based number and severity of negative factors, consider reiterating some areas of extracting severely involved teeth. So the last thing we have to remember is the take home message. Case history is the blueprint of the treatment plan. Appropriate treatment plan may prevent unnecessary complication. Case history provides detailed information regarding risk factors associated with disease progression. Thank you so much. So this was all about the case history in periodontology. Stay tuned for another videos. Kindly like, share and subscribe. Thank you.